So very good evening and welcome all of you for this third online PG classes, which is going to be organized on the banner of the UP-AROI chapter. So for the moderation, I would like to invite Dr. Sambit Swarupananda. He is the Assistant Professor, Radiation Oncology at VCH Varanasi. Dr. Sambit, it is for you.
A very good evening to everyone. And today, this is the second class under the banner of UP-AROI, under the leadership of Professor Salim Kumar sir, Professor Surbi Gupta ma'am, and I am thankful to them for giving me the opportunity. Without wasting much of the time, I would like to introduce today's panelist, Dr.K.C.Patro sir, who is the head of the department, Mahatma Gandhi Cancer Hospital, Visakhapatnam. He has very special interest in the neuro-oncology specifically. He's a very good orator and has been part of various AROI and NICRO programs. And one of the important thing is that his innovative idea of oncology cartoons have been a very big hit among the oncology community. So he will be talking on the topic of pathological classification of the brain tumor diagnostic workup. And over to you, sir.
Good evening to all. Thank you for nice introduction, Dr. Sambit. I am going to discuss about the recently published WHO brain tumor classification in nutshell. I am not a pathologist, but I know what a radiation oncologist should know. So I am just going through the overlooking the brain tumor classification published in the by WHO, and hope I will answer your all questions. So if you see the first slide, the left-handed boy is smiling that my glioblastoma patient is doing well for a long time, but other person is crying that my grade 2 glioma patient is not doing well. So why this thing happens? So if you see, if you enjoy the cartoon, if there is a in this all the things, why this glioblastoma multiforme is doing well and grade 2 glioma is not doing well. So in all these things there is a molecular basis. If this all things related to the IDH, isocited dehydrogenase. So what is the isocited dehydrogenase? There are three enzymes: IDH1, IDH2 and IDH3. IDH1 in the cytoplasm, IDH2 and IDH3 in the nucleus. So what happens when there is a citrate to alpha ketoglutarate in a citric acid cycle? This IDH1 by IDH and alpha ketoglutarate, and this provides the amino acids for the normal cell cycle functioning. But when there is a tumor, genesis, if there is a problem, this thing it produces a called dehydroxyglutarate. This dehydroxyglutarate, which is mostly these things are leads to tumorigenesis in the cell, and this alpha ketoglutarate dependent deoxygenase, this enzyme is dependent on the alpha ketoglutarate. If mutant IDH1 is the mutant here, this will inhibit this all tumorigenesis pathway. And if you see this alpha ketoglutarate, if there is a IDH mutation, this 2-hydroxyglutarate inhibit all the gliomagenesis pathway. So this is what is the main mechanism out of IDH mutation. And IDH1, IDH2 mutation is most important. There is a hardly will found the IDH3 mutation. So all the behavior is decided by not by the histopathology. Mostly it decided by the altered molecular behavior. So in older days, before 2016, what we are thinking that histopathology is the important and it will decide your behavior. But in molecular alteration, now the molecular alteration which decides the histopathology, not the decide the behavior of the tumor, not the histopathology. So what is molecular profiling? Molecular profiling or tumor genomic profiling is a form of testing that classifies tumor based on the genetic makeup to diagnose and treat cancer. Molecular testing such as a molecular profiling of brain tumor improves the diagnostic accuracy, allows the predictive and prognosis, enables the target identification. At present, targeted therapy has become the one of the most promising treatment options for many tumors. Today, it one targeting a site may be the prognostic value, tomorrow it may be the predictive value. So, molecular profiling is very important in the WHO, in the brain tumor classification. So, if you see the brain tumor diagnosis, first the microscopic histology based on the what is the cell, what is the tissue, we do diagnosis. Then came the immunohistochemistry. Based on the immunohistochemistry, we do the brain tumor diagnosis. Then next generation sequence, then methylation profiling. These are the 4 ways where the it improved. So if you see, this is the this is the histopathological diagnosis. If you see this cell, this is a multinucleated giant cell. This is the atypical mitosis. This is the necrosis. On the basis of this, it goes to a anaplastic astrocytoma or glioblastoma. So previously on this basis only we decide the tumor. Now slowly they came IHC marker. IHC marker is nothing, antigen, antibody and fluorescent level marker. Direct either indirect method, you can diagnose the tumor by IHC marking. Slowly it came to the next generation sequence. In the next generation sequence, you have to do the input DNA, they do the fragmentation, they have to adapter ligation, then sequencing, and then compare with a library of DNA and RNA sequences, and they will diagnose the tumor. After that, there is a methylation profiling. What is methylation profiling? Methylation analysis is the study of chromosomal pattern of DNA or histone modification by a methyl grouping. So these are the slowly evolving diagnostic utility in the brain tumor. So sometimes NGS sequence panel or methylation profiling is not available. So sometimes NGS panel or methylation profiling is not available. So sometimes cheap surrogate immunohistochemistry marker is available, and we can diagnose with the molecular profiling by surrogate immunohistochemistry. So if you see this, this lady is not just looks like Aishwarya Rai, but this is she is not the Aishwarya Rai. She is the Sneha Ulal. She acted in various movies and like, so if you see the morphologically, they look like Aishwarya Rai, but if you do the genetical profiling, they both are different. Like that, we have to let's discuss something like that tumor, like in the application in the brain tumor. So see, this is the histological finding. This is known as a mixed glioneural tumor. Glioneural tumor. If you see it will mimic the histology. It looks like a DNet. But if you go to the molecular profiling, mutation in PDGFR gene, it diagnosed as a mixed glioneural tumor. Another similar mimicking is like embryonal tumor. The histopathology looks like embryonal tumor. I am not going to the details about the histopathology because only just understanding purpose I am giving an examples. So if you see, this is known as a diffuse hemispheric glioma, and these are the new entities in the 2006-21 classification. This is the H3 G34 mutant. If you see the diffuse hemispheric glioma H3 G34 mutant towards the diagnosis of diffuse hemispheric glioma. Another is the new entity in the called polymorphous low-grade neuroepithelial tumors of young, that is looks like a oligodendroglioma. If you see the loose cells, perinuclear hollow, these are all indicating the diagnosis of oligodendroglioma histopathologically, but CD34 immunoreactivity and MAP kinase pathway alteration is going, the tumor diagnosis goes towards the planting. Another thing, again, this loose cells, perinuclear hollow tissue diagnosed looks like a oligodendroglioma, but it is a new entity called multinodular and vacuolytic neuronal tumor. Another is the CNS, again, if you see, it looks like a embryonal histology, and this is like a looks like anaplastic ependymoma, but because of Becker gene mutation, internal tendon duplication, the tumor, this is the another entity in the 2021 classification. Again, desmoplastic myxoid tumor of the pineal region with a SMARS B1 mutation. The other pineal region, the histology looks like myxoid stroma and loose cells. It looks like a pilocytic astrocytoma or pineal gland tumors, but SMARS B1 mutation, it looks taking the diagnosis towards the desmoplastic myxoid tumor of the pineal region. Another new entity is called Pituitary Blastoma in 2021 classification. This is the mimicking a embryonal glioma. If there is a DICER1 gene mutation, because of DICER1 gene mutation, the diagnosis goes towards the pituitary blastoma. And these are the four other histologies, which is non-meningothelial mesenchymal tumor with different mutations. So, whatever maybe you have to do the molecular profiling if it is available. So, at last, what I am telling, molecular alteration decides the behavior of tumor, not the histopathology. So, if you come to the World Health Organization's website, there is a called IARC. This is known as the International Agency for Research on Cancer. Is the specialized cancer agency of the World Health Organization. The IRC is to promote the international collaboration with cancer research, the publications, authoritative series, handbooks, textbooks, what they are publication. WHO Press will publish all these documentation. If you go to the WHO classification website and IIRC publications, you will find not only the central nervous system classification, you will there are many tumor classifications you will on the on the board. So, if you see the evaluation of brain tumor classification by WHO, the first edition came into the picture in 1979, second edition came in 1993, third edition came in the 2000, fourth edition came in 2007, and fourth edition revision came in 2016 after 9 years gap. So, if you see the fourth from 1979 to the 2007, it is based upon the only morphological features, but 2004th edition, now the new classification came in 2021, it is based upon the integration of morphology and molecular pictures. So, what happened between 2016 and 2021? Why there is a 5 years? What happened in these 5 years? So, they formed a group called C Impact Now group. C Impact Now group is nothing, is a the consortium to inform molecular and practical approach to CNS tumor taxonomy. This is a group formed by neurosurgeons, neuropathologists, and neurologists. So, this group gave by year 7 recommendations to implement all these things in the upcoming 2021 classification. So, what is his recommendation 1? So, they have classified NOS, what is NOS and what is NEC, not otherwise specified. NOS means not otherwise specified. Now, NEC means not elsewhere classified. So, this is called recommendation 1. Recommendation 2, they classified that midline diffuse glioma has 3 histone mutant. It is not all mutations in this not carries all dismal prognosis. Usually, if you do the histone mutation in diffuse midline glioma, usually we think that it is a poor prognosis, but they told that all tumors with histone mutation does not carries the poor prognosis. And they were given another recommendation that diffuse astrocytoma IDH mutant can be diagnosed with using ATRX or p53 expression as a ISC surrogate markers for absence of 1p19q co-deletion. So, if there is an absence of 1p19 co-deletion, you can take as a ATRX ISC. Another recognizes the histological low-grade astrocytoma is IDH wild type to IDH wild type glioblastoma. So, if the diffuse astrocytoma, which is low grade, but IDH wild type, histological looks low grade, but IDH wild type, which factors it is, what molecular profiling you go for the is a IDH wild type glioblastoma. They told that chromosome 7, gain in chromosome 7 or loss in chromosome 10, TOT promoter mutation, UG for amplification, you should regard it as a grade 4. In fourth recommendation, molecular they defined the pediatric gliomas into various molecular alterations. In grade 5 recommendation, they told that even in IDH mutated glioma, if there is a CDKN2A deletion, it acts like as a grade 4 glioma and having malignant behavior. In grade 6 recommendation, they given new entities and diagnostic principle for upcoming CNS tumor classification and grading. In grade 7 recommendation, they redefined the Hypername using the molecular pictures. So these are the all 7 recommendations they have given between 2016 to the 2021, and they incorporated all these 7 recommendations into the 2021 classification. If you want to remember or want to go through the 7 recommendations, this article says all these recommendations, you can go through it. So let's come to the 2021 classification, which is published in the Neuro-Oncology by David Lewis in June 2021. So what are the highlights of 2021 WHO brain tumor classification? Before going to the detailed picture, I will tell about what are the highlights. First, there are new 22 entries. New entries are 22. Revised terminology is 13. They used Romanic in place of Romanic numbers. They used the Arabic numbers. So Arabic numbers they used now. Romanic numbers are no more used. There is no word called anaplastic word. There every tumor there is essential diagnostic criteria. There is a desirable diagnostic criteria. So for diagnosis you need essential diagnostic criteria, desirable diagnostic criteria. They divide into the diffuse gliomas into adult diffuse low grade glioma, pediatric diffuse low grade glioma, and gliomas, glioneuronal tumors, they divide into 6 different families. The type is used instead of entity and subtype is used instead of variant. And they defined the NOS, 2 words, NOS and NEC. What is NOS and what is NEC? NOS is not otherwise specified. An NOS suffix indicates that a diagnostic information necessary to assign a specific diagnostic is not available either by technically or not undertaken the molecular profiling. Then you can write as a NOS. Not elsewhere classified, you did extensive molecular profiling, but it is not fitting to any WHO classification, then it is called not elsewhere classified. So as I told, Romanic numbers they no longer it is used. Now they are using the only 1, 2, 3, 4 is Arabic numbers. And all tumors they grading all the on the basis of Arabic numbers. As I told, there is no anaplastic word like anaplastic ependymoma, anaplastic astrocytoma, anaplastic meningioma. The anaplastic word is no more used. In place of anaplastic, they used WHO grade 3. This is not 3. This is you should use Arabic number. So if you go to the histopathology of the glioma, there is a called MN score. MN means A for atypia, M for mitosis, E for endothelial proliferation, N for necrosis. So this basis on the MN score, you can diagnose in the histological classification. So if you see astrocytoma IDH mutant grade 2, astrocytoma IDH mutant grade 2, if there is no anaplasia, no mitotic activity, no microvascular formation, and no CDKN2B deletion, then it is called as astrocytoma grade 2 IDH mutant. If there is a dispersed anaplasia and significant mitotic activity, but no microvascular proliferation, no necrosis, no CDKN2B deletion, then it is grade 3. If you are finding necrosis, CDKN2B deletion, and microvascular proliferation, though it is identity mutant, you can take as a grade 4. So definition of glioblastoma, what is IDH wild type? One or more of the following pictures like microvascular proliferation, necrosis, TOT promoter mutation, EGFR amplification, gain in chromosome 7 and loss in 10th chromosome copy number alteration, it is regarded as the glioblastoma multiforme. Not glioblastoma multiforme, it is a glioblastoma. That multiforme does not exist now. So only grading is not longer entirely histological basis, it is a molecular basis. So grading is no longer entirely histological. The presence of CDKN2B homozygote deletion results in a CNS WHO grade 4 even in absence of microvascular proliferation. Remember, CDKN2AB deletion in a IDH mutant glioma, even in absence of microproliferation and necrosis, it is regarded as a grade 4. IDH altered astrocytoma with low grade histological feature can be considered as a grade 4 in the presence of EGFR amplification, TOT promoter mutation, and chromosome 7 combined gain in chromosome 7 and loss of chromosome 10. So if you see the CDKN2B deletion, even it is IDH mutant, if it is a CDKN2AB deletion, there is a poor prognosis. But in this literature, it says that if the CDKN2AB deletion is there, it is mostly affect the astrocytoma, oligoastrocytoma tumors rather than oligo components. So if you if it is a after adjustment of IDH mutation, sex and age, CDKN2A deletion strongly with the poorer survival in astrocytoma, but not in oligodendroglioma and oligoastrocytoma. So this is the deletion status. Hopefully it will come in our regular practice. So when I will call as a glioblastoma, diffuse astrocytoma with wild type with TOT promoter mutation, necrosis, microvascular proliferation, EGFR amplification, and gain in chromosome 7, a combined gain of chromosome 7 and loss of chromosome 10. Grading of IDH mutant, again 2 to 4 as I discussed. There is no glioblastoma ward in the pediatric group. Giant cell glioblastoma, gliosarcoma are not listed in the classification. So let's take layout reporting in brain tumors. This is based on the Harlem consensus guideline. So on this base, if you any tumor, histological diagnosis, grading, and molecular profiling, these lower 3 criteria, it will decide your integrated diagnosis in the up. Let's take some examples. If there is a histopathological classification is oligodendroglioma, grading not assigned, molecular profile information is duplication of FGFR tyrosine kinase domain by next generation sequencing. So the integrated diagnosis is diffuse low grade glioma, MEP kinase pathway altered, and subtype is FGFR TKD duplicated. Another thing, integrated histopathological classification is Hypername, CNS grade is 3, and molecular information is derived from the tissue is insufficient. So technically it is a failure. So integrated diagnosis is supratentorial ependymoma with grade 3 and NOS, not otherwise specified. So when the technicality difficulty is there, you are not able to do the molecular information, then it is regarded as a NOS. They told you have to do some essential diagnostic criteria and desirable diagnostic criteria. So essential diagnostic criteria, this must have these pictures, and desirable diagnostic are nice to have the pictures. So if you see any glioblastoma IDH wild type grade 4, these are the, as I told, macrovascular proliferation, necrosis, TOT promoter mutation, EGFR amplification, chromosome 7, 10 abnormality together. These are the, for glioblastoma diagnosis, these are the most essential criteria. But desirable diagnosis, these are like DNA methylation profiling, all these things, desired diagnostic criteria you can do, or if possible you can do, but essential diagnostic criteria you should do. As I told, there are 22 new entries and revised terminology is 13. So if you see, these are the new entries in 22. These are the new tumors entered in the WHO 5th edition classification. Some examples as I give: diffuse astrocytoma, MEB and MEB-L1 altered, polymorphous low-grade neuroepithelial tumor of young like Planty, diffuse low-grade glioma, MEP kinase pathway altered. These are the various new 22 entries into the classification. So in 20 out of in this 22, 7 are new gliomas, 3 glioneural tumors, 4 ependymoma, 4 embryonal tumors, 3 sarcomas, 1 pituitary, that is pituitary blastoma. These are the 22 new entries in the WHO classification. There are revised terminology, it is 13 numbers. But I will give an example. Suppose there is a supratentorial ependymoma which is known before is a rela fusion positive, now it is a JAPTA fusion positive. Like that, diffuse medullary glioma which is known as a H3K27 mutated in old classification, now it is altered. So they divided into the gliomas into adult diffuse low grade glioma and pediatric low grade glioma. So they have divided into 6 groups: glial tumors, adult diffuse low grade gliomas, pediatric low grade gliomas, pediatric diffuse high grade gliomas, circumscribed astrocytic gliomas, glioneuronal and neuronal tumors, ependymomas. Choroid plexus tumor is a different entity. 14 gliomas and glioneural tumors and neuronal tumors are newly 14 tumors. These all tumors based on the histology, immunohistochemistry and molecular profiling, together known as a HIM. So all these tumors based on the histological, immunohistochemical and molecular profiling. So these are the glial and glioneural tumors. But these are the glial and glioneural tumors, and these are the 6 groups: adult diffuse low grade glioma, adult diffuse glioma, pediatric diffuse low grade glioma, pediatric high grade glioma, circumscribed astrocytic tumors. These are the main classification. What are the circumscribed gliomas? It is well defined, as you know, name defines. You can remember as a shape, that is subependymal giant cell astrocytoma. H for high grade astrocytoma with plioid features, astroblastoma M1 MN1 altered, pilocytic astrocytoma in extra pleomorphic xanthostrocytoma and choroid glioma. These are the mostly taken as a circumscribed glioma. If you see the changes in the glioma classification in the compare with 2016 to 2021, there are many numbers in the 2016, but in 2021 only 3 groups are there: adult diffuse glioma, that is astrocytoma with IDH mutant, oligodendroglioma IDH mutant 1p19 co-deleted, and glioblastoma IDH wild type. So only 3 types. So if you see diffuse glioma in 2021 classification, one is mutant with deletion, and otherwise wild. So only 3 groups. So pediatric glioma, again WHO, if you see the pediatric glioma, these are the new entries. So they divide into pediatric diffuse low grade glioma, pediatric diffuse high grade glioma. There are 4 in each group. In pediatric low grade glioma, diffuse astrocytoma MEB and MEB-L1 altered, angiocentric glioma, polymorphous low grade neuroepithelial tumor of young, diffuse low grade glioma, MEP kinase pathway altered. This is the pediatric diffuse low grade glioma. Pediatric diffuse high grade gliomas, this is mostly on the location based, like diffuse midline glioma, H3K27 altered, diffuse hemispheric glioma, H3 G34 mutant, diffuse pediatric type high grade glioma, H3 wild type, IDH wild type, infant type hemispheric glioma. So pediatric diffuse high grade gliomas, previously known as a H3K27 mutant, now it is known as a altered. You should not use the word mutant, because there is many pathways involved in this molecular alteration. So they named as a altered rather than as a mutated. So these are the various common pediatric gliomas, pediatric tumors with some molecular alterations, and you can see the prognosis, which is poor and which is good and which is excellent. You can go through this article and you can classify your tumor. Again, tumors of cellular origin. If you see the adventitious craniopharyngiomas like adventitious and papillary craniopharyngiomas are different entity, now came under the single group. This is the cellular origin adventitious type craniopharyngioma, papillary craniopharyngioma, pituitary net neuroendocrine tumor, pituitary blastoma, and pituitary cytoma. And these are the various molecular alterations in the adventitious, like adventitious craniopharyngioma, that is CTNNB1, and papillary craniopharyngioma BRAF alteration. So these are the changes in the cellular classification. Meningioma, there are in CNS fifth classification there are 15 types. There is no atypical or anaplastic word. All are grade 2 and grade 3. In prior classification, choroid and clear cell meningioma, which is regarded as the grade 1 meningioma, now taken as to grade 2. Rhabdoid and papillary morphology qualified for the grade 3 irrespective of their indication for malignancy. And several molecular markers also associated with meningioma. If you see SMART C1 is a clear cell type, BAP1 in rhabdoid and papillary subtype, KLA4 and TRFA7 that is secreted type subtype mutations. So these are the meningioma molecular alterations. If you can, the interested people, they can go and study this molecular alteration. Hypername classification is again very drastic change. It is based upon the location as well as based on the molecular alteration. So they divided into 3 groups. One is the supratentorial ependymoma, one is the posterior fossa ependymoma, one is the spinal ependymoma, and 2 different entities. So if you see supratentorial ependymoma, which is previously known as a RELA fusion, now it is JAPTA fusion. Supratentorial ependymoma YAP1 positive, posterior fossa ependymoma group A and group B. Spinal ependymoma with MECAN amplified. Another is the entity is myxopapillary ependymoma and subependymoma. So these are the it is based mostly on the location as well as the molecular alteration. If you see the which is good prognosis and what is the poor prognosis, what is the excellent prognosis, you can go with the supratentorial, infratentorial, and spinal, and you can see the outcomes. If you want to go through details, you can go for the molecular classification of ependymal tumors. Changing in the medulloblastoma classification, that is they are defined mostly molecularly altered and histologically altered. So previously classification 2004, 2016 there were 4 morphological type like classic, desmoplastic, nodular malignoma. Now they were all taken together as a medulloblastoma, histological defined, and they have a 3 molecular defined Wnt, SHH, and non-Wnt and non-SHH. So SHH is the sonic head pathway, Wnt pathway, and so this is medulloblastoma Wnt activated, medulloblastoma scenic activated with p53 wild type, another is p53 mutant, and medulloblastoma non-Wnt and non-SHH. If you see, this is the 4 groups in the SHH group. I am not going to the details of the this classification. And group 3, group 4 medulloblastomas, again it is 8 subgroups. You can see here 1, 2, 3, 4, 5, it is 8 subgroups, and you can go through the which is good prognosis, which is poor prognosis, what is the common in adult, what is the metastasis common. You can go and study in the molecular profiling. Other CNS tumors, few CNS tumors they have given like atypical teratoid rhabdoid tumor, cribriform neuroepithelial tumor is known as a crinate, embryonal tumor with multilayered rosette is known as ETMR, CNS neuroblastoma FOXR2 activated, CNS tumor with Beaker internal tendon duplication, and CNS embryonal tumor. These are the various other tumors. You can see this ATRT as again 4 subgroups, MEEK, SHH, TAIR, and cribriform neuroepithelial tumor. These are the various subgroups, and this is the other tumors. You can, if you are interested, you can go again to the study the embryonal tumors. Again, pineal gland tumors, neoplasms that include pinocytomas, pineal parenchymal of intermediate origin, that is PPTID, pineoblastoma, papillary tumor of the pineal origin. So these are the neoplasms, and pineoblastoma again 4 molecular subtypes. This is the DICER1, DROSA, and DGCR8 mutation, which is seen in adult and in older children. MEEK and FOXR2 activated, having MEEK activation, FOXR2 overexpression. Pineoblastoma, it is RB1 gene altered in infants with similar to retinoblastomas. So these are the various molecular alterations. You can see there are various 4 groups: pineoblastoma and pineoblastoma, pineal parenchymal tumor of intermediate differentiation. Again, you can go through it. I am not going to the details of these pineal parenchymal tumors and pineoblastomas. It may take long time. So hemangiopericytoma, again if you see hemangiopericytoma, the word does not exist now. So the tumor is known as a solitary fibrous tumor. It is not related to the any meningioma groups. It is like a soft tissue pathology, soft tissue tumor pathology. And why they have changed? To provide the more flexibility using the grade related to the tumor type, biologically similar to the sarcoma, and this is a to confirm WD is a non-CNS tumor type. So there is no hemangiopericytoma ward is existing now. So these are the various molecular alteration in various tumors. You can go through it, and these are the various classifications, various molecular alteration in the various tumors. I am not going to details. This is the basics what I explained you. And so what is the summary? It is a long way to go. Better understanding is required for the clinical implementation. Very few centers are doing the molecular marking. Over the time, some molecular markers will act as a predictive marker. So if you are not able to do the molecular profiling, and nothing to worry, slowly it will come to practice over the years, and time will tell about the molecular profiling, and slowly we will implement in our clinical practice. Thank you very much for the inviting me at the talk. Hope I send some message. If anybody have questions, they can ask, and I will love to answer.
Thank you, Dr. Kanu, for a very elaborate topic. The presentation has been excellent. In the beginning, you have said that you are not a pathologist, but the extent to which you have described it, it is better than any pathologist, at least the ones I know. So I would like to entertain if there is any questions from anyone. We have got a question, sir. What are the common molecular testing you order for GBM based on the new classification as recommended by WHO?
So actually, in our clinical practice, we don't do all molecular alterations, because few molecular. So at least any glioma comes to us, we do the IDH mutation, status, ATRX, and co-deletion status. So these things, first you do the IDH mutation, and if you are during the if ATRX IDH mutation, then you can think of the whether you will go for the co-deletion status or not. But if there is a no IDH mutation, it is wild, you stop. You can stop your further molecular profiling. Or if you want to, if you are the IDH mutant, if there is a CDKN2B co-deletion deletion status, all other things I have not started in the practicing, because this is available in only few centers in the country.
So there is one more question. Is there the term gliosarcoma still existing in the 2021 classification?
No, gliosarcoma they have explained, but they are not in the classification.
Okay, sir. And sir, what about the S3K27 mutation? Do you do that on all pediatric cases routinely, or is it?
Those are midline glioma. Those are midline glioma. We do that actually. I think that is available in some centers. Yeah, even low, very. Now I think all metro cities. So now the only one thing is that we should not use the IDH, sorry, H3K27 mutation. You have to use a word called H3K27 altered, because lots of molecular alteration happens. So they taken the mutation word out and put the H3K27 altered.
Okay, sir. We have got another question. Can IDH wild type be the sole basis for use of concurrent and adjuvant temozolomide?
So there is a issue, NSO Neuro Society Oncology ASCO, they have published an article now. So it will take, so even they ask the in low grade gliomas IDH mutant as well as IDH wild, you can use temozolomide, even they recommended it.
Sir, even for low grade gliomas, like in grade
they recommended that you can go for the temozolomide also.
Okay, sir. In that, do you prefer PCB more than temozolomide, or temozolomide more than PCB?
PCB is the more evidence-based rather than temozolomide in low-grade glioma. But PCB, the availability of a drug, implication, availability, as well as the use of temozolomide 1 drug, PCB 3 drug. Yes. You use temozolomide 5 days, PCB there is a protocol. So 3 drugs regimen, it is 1 drug regimen, and temozolomide single capsule 5 days sufficient, but it is a 4 weeks, 6 weeks. So this is a 3 weeks. So it is a very tough to handle actually.
Okay.
So I prefer temozolomide rather than PCV, but PCV has more evidence than temozolomide.
Yes, definitely. One question I have on of my own, sir. Is there hemangiopericytoma term still used?
No, as I told, the hemangiopericytoma is not. We think that it is a meningioma variety. Meningioma, I usually call as a brother sister, but now they meningioma hemangiopericytoma is no longer is a meningioma group. It is in the sarcoma group, non-CNS tumor classification.
Sir, what about the solitary fibrous tumor?
That is the solitary fibrous. That word only replace the hemangiopericytoma.
Yeah. Okay, sir. We've got a few more questions. Is there any upcoming use of lomustine for GBM patients who have failed on temozolomide, or do we still keep Avastin as the second line?
See, today I have sent the cartoon about the glioblastoma, that is a Avastin, about the bevacizumab. They don't recommend upfront glioblastoma as a bevacizumab. So bevacizumab should not be started upfront in the glioblastoma. First thing. Second thing, if you give, it is a new, it inhibits the new angiogenesis. So any patient with if you give a recurrent glioblastoma where there is other options are not available, if you give the bevacizumab, it normalizes the vasculature. So you will think a good you will think that there is a response, but it is not a really response. It is a called pseudo response. The tumor does not decrease. Only the vasculature become normal, and patient having slightly good, better quality of life. So this is the bevacizumab story. And the second thing is, we don't use PCV regimens. These are all in the clinical trial. If you go to the guideline, that ASCO guideline, they tell it is a physician choice, or any clinical trial you can go for the recurrent glioblastoma.
Definitely, sir. Sir, how about the management? Does it vary with the molecular subgrouping in the medulloblastoma?
Yeah. Now, last few years, we started the molecular profiling of the medulloblastomas, and as you see, there do the article published by the Tejpal Gupta sir and group, and you can see the radiogenomics of the various molecular profiling, which is a good prognosis. You can do the dose reduction, but still I prefer as a normal. I treat as a normal because as I am a periphery, I treat this old protocol like 35 grade 21 fraction for the CSI, and followed by boost. Because sometimes we are not able to go through the molecular profiling properly.
Sir, there has been a lot of debate regarding the BCOR mutation, specifically in case of Ewing sarcomas and all that, it is associated with poor prognosis. There is mention of BCOR mutation in the new classification. Can you enlighten us something about that, sir?
Now I didn't go through the all individual tumors. I will come slowly. Yeah, I'm sorry.
Definitely, sir. Because this is a new horizon altogether, and
I
any
will,
insight to it is definitely better than the previous scenario. All of us are learning, definitely, and we are in a situation where the profile has increased significantly, and we have to be somewhat pathologist to understand the classification itself. Then there will be the management part.
yeah. So that any more questions you can ask. Only the molecular profiling I tell, don't worry for the molecular profiling, don't change your policy now. So slowly we are going to learn, and implication of molecular profiling in the clinical practice, it will take time.
Okay, sir. Definitely, sir. Sir, thank you. Thank you for a nice presentation. Thank you for a great QA session, for answering all the questions on a topic which is brand new, and It is very difficult for all of us to even understand what you are saying. We can understand how much in depth we have done the research just to make sure that you get to explain all these things to us. Thank you very much, and hope we'll meet on the next class for the UP-AROI sessions to continue.
Thank you, Dr. Patro. Thank you so much. You elaborated so much pathological aspects of the CNS tumors. And management part will cover on the next 2 sessions. And your next class is supposed to be on Wednesday, next Wednesday, on non-gliomatous tumor. So we'll be happy to hear you again. Thank you so much, Dr. Patro again. Dr. Sambit, thank you so much for such an interactive session. So thank you, all of you, all the participants for joining us. And for next class, I will share the link with your mail ID. Thank you so much. Thank you, Avinashji, for providing a platform. Thank you.